Are we wide awake at 8:30 in the morning? Yes? No? Okay, well, I would like to say first that I am honored to be here to ask, excuse me, I'm a little nervous. I am honored to be here. Being asked to speak here in front of you all, really is a great accomplishment for me. And I feel honored to be able to give back to a community which has given so much to me over the years. So thank you again for having me here today. So what is my presentation about? The theme this year is creating accessible health care for the deaf. Well, in my recent graduate studies, I did a research paper, conducted focus groups within the deaf community to determine what are some of the challenges in the medical community with regards to communicating with the deaf. So that's what we'll be discussing today. So during the course of our hour and a half here together, this is what we'll be discussing. I'll tell you a little bit about myself, who I am, and how it is that I come to you this morning. We'll discuss healthcare communication. What is that and why is it important? How does it impact the deaf community? We'll discuss some of the previous healthcare communication research and then go into my particular study, which was done in two parts. The first part of the study was focus groups conducted within the St. Louis area in the deaf community, asking about your communication challenges. Based on the responses that I received in the focus group, I then went on to create a training project with collaboration with Deaf Inc. for medical professionals. So we'll try to cover everything, and at the end we'll see a portion of the video, and I will entertain any questions that you might have about the research or what we can do in the future. So who am I? I'm Valerie Shaw. I was born and raised in Los Angeles, California. Is this better? Thank you. Okay, so I was born in Los Angeles, California, born and raised there. And everybody always wants to know, so why did you come into interpreting or the deaf community? While in high school, at a medical magnet high school in California, I wanted to become a doctor. I met a young lady there who was deaf, and she was really good in calculus, and I wasn't. So I went to her one day and asked her if she would help me, and she said no. I got an attitude and left. And maybe about a week or so later, I'd been watching her, and I sat down and I wrote her a note, and I asked her if she would teach me how to sign, and she said yes. And that was the start of our friendship. I wish I could find her now. I've been searching for her because she really changed the course of my life just in that instant. So that was my first exposure to the deaf community. After graduating high school, I immediately went into the interpreting program at Cal State Northridge, where I was there for 2 years. And as most of us when we're young, we don't really know if that's what we want to do or not. So, I stopped going to school and got a job and started moving around America. And I landed at the post office in Jackson, Mississippi, where there's a lot of deaf people who work at the post office. And they kept encouraging me to go back to school. They said, go back, become an interpreter. So finally, with a lot of prayer, I quit my job, moved to St. Louis, started at Florissant Valley, and graduated from Florissant Valley in 2006. So after I graduated, I said, why stop there? I originally started a bachelor's level program. I want to finish a bachelor's level program. So I decided to take my time to commute back and forth to McMurray College, which is in Jacksonville, Illinois, where I received my bachelor's degree in interpreting in December of 2007. And now after I graduated from Flow Valley, I became certified worker in the community. And when I got my level 4, I started to notice challenges in the medical setting. Whenever I would show up to interpret, I would notice these communication challenges between the doctor and the patient. The doctor didn't know how to utilize an interpreter and things of that nature. But most of the time, we're the silent partners. So I said to myself, what can I do about this? We always talk about the dumb doctor. He doesn't know this, he doesn't know that. And I said, well, maybe we need to educate the doctor. So I decided to go back to school at SIUE and and joined the speech communication department with an emphasis in healthcare communication. And I felt that that would be my way to try to educate and give back, educate the doctors and also give back to the community that I work in and I serve and I love. So I finished my master's degree in May of this year. It took me 3 years. I did an extra year. So I was very excited about that, and I'm also very excited about the work that I've been doing. So let's go on and see what's happening with the healthcare communication. So what is healthcare communication? Healthcare communication is the study and use of communication strategies to inform and influence individual decisions that enhance health. The particular goals of healthcare communication is to disseminate useful health information to the public to increase awareness of specific aspects of the individual and collective. So healthcare communication in the past had primarily been either written or verbal. But in our recent technology age, we have things like DeafMD, which is a form of healthcare communication. It's informing you about particular aspects of disease and illness. And it encompasses education, health journalism, interpersonal communication, media advocacy, and organizational communication, and risk communication. So what we do is we come into a particular health situation, we analyze the communication that's going on, and try to find out where are the barriers, where are the breakdowns. Once we find that breakdown, we go to a target community, and in this situation, our target community was the deaf community. And we ask them, so what are your challenges? I know what I think they are, but I'm not deaf. So we come and ask you, what are your particular challenges? Once we find out what those challenges are and what you think might be beneficial to the situation, we sit down and try to produce some type of message to educate the doctors. That's what I'm doing in this particular situation. Sometimes healthcare communicators are enlisted when there's some sort of risk that's going on. When a salmonella breakout occurs or something like that, or West Nile virus, and you hear the stuff on the news, trust and know they talk to a healthcare communicator because they want to know how to inform the public. They don't want to scare people, but they want to keep them informed. So they come to someone like myself and ask, what's the best way to deliver this message to this population? So why is it important? Communication with a patient is an important part of diagnosis, treatment, and management of illness. If you cannot communicate with your healthcare professional, you cannot get your needs met. You might not know how to take that medication. You might not know what you need to do when you go home. So communication is the first step. Also, the success of healthcare depends upon the ability of the patient and the provider to communicate effectively. And cultural differences, if they're not addressed appropriately, can hinder the communication. I'm sure you've all experienced this yourselves when you go to the doctor or when you go to the hospital. If you cannot communicate effectively, you might not get the treatment that you need. And studies have proven that doctors, in the first 3 minutes of discussion, have already made a decision about your diagnosis and your treatment. So if in the first 3 minutes you cannot communicate effectively what your issue is, there might be some problem with the diagnosis or treatment later on. It's sort of like their brain turns off after the first 3 minutes. They've heard what you said, what's the problem? You start talking and they've automatically come up with, okay, this is what I want to do. But if you can't get that communication effective within that first 3 minutes, you might have breakdown. Also, studies have shown that cultural barriers often lead to communication misunderstandings, misdiagnosis, medication errors, missed appointment, dissatisfied treatment, and lack of medical care, or sometimes even death. We're all in this community, and we've all heard of stories of somebody taking their medication wrong. How many people have heard of a story about somebody with a medication error? Anybody? Yes, we've all heard of that. Or misunderstanding. A person at the doctor's office and they have been provided an interpreter, and the doctor tells them to take their clothes off from the waist down, and they didn't understand, and they took them off from the waist up. These kind of things do happen. It happens a lot when there's some type of barrier in communication. So it's really important not only to be able to communicate, but also to understand somebody's culture, because your culture directly affects who you are, how you respond, and what you do. So let's talk a little bit about cultural differences. Look at this picture. Does anybody know what this is? No? Good. Okay, so say somebody comes into your office, and you're a doctor, and they have these marks in their back. Say it's a child. What would you think? You would think abuse. You would think abuse. This person is being abused. Well, actually, this is an ancient Chinese alternative medicine called cupping, where they use the suction of cups. And the premise is that they put this on the skin, and the belief is that this practice will actually promote healing. Okay, well, we've grown up in America, and to us that might seem a little strange. However, this posed a problem for some Chinese immigrants. They moved here, their teachers saw these marks on their children's backs, or they've gone to the doctor, and immediately their children were taken away from them because they thought they were being abused. And because they didn't have the communication, it took them a while to get their child back. So understanding culture is really important when we're talking about diagnosis and treatment of a particular patient. Some cultures won't take certain types of medicine. Some cultures only want you to talk to the head of the house, the father. And if you talk to the woman, that's a problem. Some cultures, a man that is not your husband should not see you undressed. So if you don't know these particular cultural differences and you get into a hospital or healthcare situation, it can pose problems. And that's the same is true for the deaf community. So why is this research particularly important for the deaf community? There are approximately 10 million individuals who report being deaf or hard of hearing. That's according to Mitchell at Gallaudet University. The numbers have been sort of hard to break down because there's no full sort of study of how many deaf people are in America. He sort of took a couple of studies and put them together to come up with this number. But 10 million individuals, that's a lot. Also, the Americans with Disability Act was passed in the 1990s, and it provides for communication access for the deaf and hard of hearing. However, the studies still indicate that deaf people are dissatisfied when going into a medical situation. So there's been other national laws that have been passed. There's been the class standards, which are culturally and linguistically appropriate services, put out by the Office of Minority Health. The Joint Commission, who governs hospitals, have recently come out with some new standards that I know James Frost is going to talk with you about later on in the day. There's different state laws. So even though we've had this national legislation, the deaf community is still dissatisfied with their services in a healthcare setting. So 1990s, that was a while ago, right? 20 something years ago. And we're still having this challenge today. And the other reason why this is important is because studies have indicated that the outcome of culturally competent care can actually increase the trust of the patient, which leads to patient satisfaction. If you trust your physician, you're satisfied when you go. Also, it increases adherence to treatment, because if we know that this culture doesn't adhere to this medication and the doctor decides to prescribe something else that they will take, we've taken into account their culture. Also, it improves care. If you can provide culturally competent communication, it will improve the care of your patient. So what happens when this doctor hands you a paper that's written on the 11th to 12th grade reading level, which, by the way, studies have also shown that hearing Americans don't understand it either. So it's not just an issue with the deaf community. But suppose he hands you this piece of paper and you go to read it, and there are all these words on here you do not understand. Now, studies have sort of shown that the average literacy score of the deaf are also similar to the literacy scores of immigrants who come into this country, which makes sense. They have a different language and a different culture. So, and ASL has its own grammar, structure, and syntax, as we know. And often, deaf patients are a lot different than the other minorities that are in this country, because deaf patients are expected to have a fluency in English. If somebody from China or comes over here, we don't expect them to be able to read English. We have materials printed in their language. If somebody moves over here from South America, we have things printed in their language. But the deaf community is the only community that is expected to have fluency in English. And it's partly because doctors don't recognize the deaf community as a separate culture. They think, you're Americans, you've lived here in America, you know English right. That's their assumption, and we have to change that assumption for them. Then we have health literacy. Now, health literacy is a challenge for America in general. It affects deaf and hard of hearing individuals in some unique ways, but many Americans struggle with low health literacy. And according to the Center for Disease Control, health literacy is defined as the degree to which individuals have the capacity to obtain, communicate, process, and understand basic health information, and to be able to make appropriate health decisions. So we have found that in the deaf community, there is less health literacy with knowledge to illness management. There's the decreased ability to participate in the decision-making process because of the low health literacy. If you don't know how, it's hard to participate. If you don't know what's out there, if you don't know the treatments, if you don't know what's happening, it's hard to participate. And also, people with low health literacy have been known to not adhere to medical instructions because maybe they think it's not important or for whatever reasons, but we know that people who have low health literacy have a hard time adhering to the treatment that's given. Now, in 2003, the National Adult Literacy Survey also tried to complete a study with the deaf community. And they did a test called Round. And what was really interesting about this test is the number one starts with the most basic questions. And then the questions get harder as you go along. What they found in the deaf community is they missed some health literacy questions at the very beginning, but then they go on and know some things, and then they miss it along the way. And what was really interesting about this particular study is that you can't pinpoint and say, okay, we need to give basic health literacy. You really have to give a full, broad spectrum with the deaf community. So it was a really interesting study, and they're trying to devise other ways to actually, test the health literacy of the deaf. So, specifically, we have found in previous studies that information access and understanding the information, patient-provider communication and relationship, access to interpreters, medical professionals' lack of intercultural communication and awareness, and also the interpreter's skill and awareness of role have been specific challenges within the healthcare community in previous research. So, we know that people are unsatisfied, they're not adhering to treatment and medical errors and low health literacy. So why is there such a disconnect? And I've talked about this already. Deaf people are foreigners. They're not seen as a linguistic minority. So doctors tend to have this disconnect. Although we're providing culturally competent care for other ethnicities and other cultural backgrounds, we're not doing it in the deaf arena. So now let's talk about my particular study. These were the research questions that I asked, and it was what communication challenges do deaf patients experience while seeking medical care? And the other question that I want answered was, what communication needs and concerns do deaf people report as being unmet while seeking medical care? So it was a qualitative focus group where we had about 3 to 4 people, sometimes 5 in a group. We had 7 groups for a total of 21. And everybody had to be a deaf community member, so they had to identify as deaf, and they also had to use ASL as their primary language and be over the age of 18. And the questions focused on information access and understandability, relationship with healthcare providers, communication issues in the healthcare setting. I provided the informed consent in written English and also on a DVD, so that it would be clear that you were volunteering to, you could quit at any time. We also attempted something called back translation, which I'm not going to go into really right now, but that didn't work. So what we did was we had 2 interpreters review the tape to make sure that we had the accurate information before we transcribed it. And then when we analyzed the data, we basically took themes. What things kept popping up again and again and again in each group that we talked with. So here's some of the results. Now I've used this little clip right here of that deaf guy. Have you guys ever seen him? I thought this was kind of funny. But the doctor asks a stupid question, and the kid says, that is a stupid question. But I think they don't know because they're not educated. So that's what we're attempting to do. I didn't show the video. Well, I'm sorry about that. I thought I was going to show the video when I clicked it, but it didn't. Can you click it there and see if it'll show? Well, it works on my computer at home. But I don't know if you all are familiar with this, but it's called a few minutes in the life of an interpreter, where the interpreter shows up and the nurse asks, questions like, well, where's the patient? Well, I don't know. I'm not his friend. I don't live with him. Or can you fill out the questions for him? Or they ask you questions instead of asking the patient the question. So that kind of thing happens all the time, and I thought it was a little funny about, that situation. So one of the things that popped up was interpreter utility. How do we use the interpreter? So most of the deaf people in the focus group said that the physicians lack training on how to use an interpreter. So the doctors always look at the interpreter or always ask the interpreter. We always hear, tell him this or ask him this. The deaf patient wants direct communication, just like we want direct communication when we go to the doctor's office. So that was one of the problems with interpreter utility. The main problem, though, was interpreter access. And we all know this. We've all heard stories of physicians refusing to provide interpreters, even though studies have shown that using interpreters improves the outcome and success of this medical encounter. A lot of physicians feel like you can read lips or just you can write back and forth and that's sufficient. And sometimes it's the monetary issue. They say it's a monetary issue. But whatever the reason, interpreter access proves to be a challenge, and especially in rural areas. So also what came up in this situation of interpreter utility is the actual interpreter training and qualification. There were many times that the deaf individual said, I don't understand that interpreter. Or that interpreter didn't understand me, and become frustrated with the encounter. And they're like, well, I thought we were supposed to be a level 4. Well, you are a level 4 or a 5. But I think part of the problem is that when we test, we're testing on language skills and not our medical language skills. So therefore, there's a breakdown. You may be able to sign beautifully, but if you don't understand what they're talking about, you can't sign it. So they felt that there should be a need for people who interpret in the medical setting there should be a need for us to have additional training, maybe in anatomy and physiology, medical terminology, and things of that nature. And I completely agree. There are some interpreters who don't, but I completely agree. The next section that came up in the focus group was information access. One was that we just don't understand it. Nothing is presented in our language. Everything is written, and it's hard to understand. You know, many people say, I go home and then I ask my daughter or my son or my uncle or my aunt, what does this mean? How am I supposed to take this medication? You should not leave the doctor's office not knowing what you should do. But it happens every day. So they cited the assistance with written material from friends and family. And also what was interesting is the groups made a distinction between information they needed for a cure to treat themselves right then, and also preventative information. The groups wanted more preventative information on different things like cancer or heart disease or diabetes or whatever. They wanted that preventative information, and they wanted it in their language. So they made several suggestions about maybe having a DVD log of certain illnesses or treatments. And that's why I like Deaf and Bleed. You know, it's sort of striving to fill that gap for medical information in your native language. So the last thing was they said, and they made, and several people said this, they don't recognize us as a culture. They don't recognize our language. They do it for every other language, but not ours. So they definitely, you know, expressed a concern that ASL was not recognized as a linguistic culture. So the other thing that came up as a theme was patient-provider relationship. Again, not only do they want the provider to be educated on how to use the interpreters, they also want the medical provider to be educated on just deaf culture in general. Some of the expectations and norms that they have prove to be unrealistic. So like lip reading is misunderstood and they don't understand why you don't understand it. Or the written information was not understood. You know, they have these unrealistic expectations. So the deaf community felt like they need to be educated about these expectations. And also the use of family and friends as interpreters. I put this little clip in here, even though it's from school. You know, he asked, can you interpret for your father? And he says, not if you're going to talk about my test, no. And that's what happens when you use family and friends as interpreters. Family and friends may have their own agenda. They might not want to tell dad that he has cancer, terminal cancer, and he's going to die. So they withhold that information. That can happen with family and friends. Sometimes family and friends don't have the training. Using a child to interpret at a medical situation, my child couldn't tell me what the doctor meant. If I asked my 9-year-old, what did he say, they wouldn't give me training because they don't know either. So it's putting undue pressure on that child to interpret for the parents. So that was part of the patient-provider relationship that came up. Also, the group came up with a list of things that they thought were welcoming behaviors from a physician and things that they thought were disrespectful. So these were the disrespectful behaviors that the group came up with. Not providing an interpreter, requiring or suggesting that the deaf patient pay for their own interpreter, not addressing the deaf person directly or looking and talking to the interpreter, using family members and friends, blocking the view of the interpreter, rushing through the appointment. And we all know that doctors rush through the appointments, but take a few extra minutes. You know, we do have a communication barrier here, and it will behoove you to take those few extra minutes that you need. So looking away while talking to the deaf patient, so if you are trying to rely on the lip reading, you can't get that information from the lips, wearing masks, and appearing irritated when the patient asks for clarification. You know, those were behaviors that they considered to be disrespectful in the groups. Some of the welcoming behaviors, just simply posting a sign. That's what was interesting to me, the simplicity of what was being asked for. that you provide ASL alternatives. You know, wanting a full explanation of diagnosis, medicine, and treatment, which anybody should have when they go to the doctor. Visual materials. You know, we all know that this is a visual community. So having that model there, or having that picture there, to be able to help explain what's going on. Using dry erase boards. Recognizing the need that there may be some communication accommodations. And welcoming the interpreter into the process. I've been to places where the doctor didn't even want me in here. We don't need you. Why are you here? We don't need you. She can read this just fine. It's spending the extra time in facing the patient and talking directly to the patient. So these were some of the behaviors that the focus group said that they consider to be welcoming when they go to the doctor. This last section was the section that touched me considerably. I'm sorry, it's the next. So deaf people as caregivers. I didn't think about this when I was running the focus group. I was thinking about directly when you go to the doctor what happens, but sometimes the deaf person is not the patient. So we have a couple of quotes from the focus group that said, I have a son who is hearing, and when he was young, the pediatrician did not want to provide an interpreter for me when I sent him to the doctor. Because the doctor said, you're not my patient. Your son is my patient. Well, I'm his mom, and I'm the one who has to go buy the medicine. I'm the one who has to give him the medicine. I'm the one who has to take care of him every day. So if I don't understand, it's not going to help him. That seems very clear to us, but obviously it's not clear to some doctors. You know, and it says legally if that woman is unconscious and cannot make decisions for herself, the son needs to be able to make decisions for his mom. But how can he do that if he does not understand? Her son is the next of kin and the doctor does not want to provide an interpreter. Again, the same situation. It was an older, you know, family member, and they had a son, and he was there to, you know, take care of his mom, and they didn't want to provide an interpreter for him. You know, and this seems basic to us. Nothing in here is rocket science. We see this every day. The problem is doctors do not do anything without the research to prove it's a problem. They want to say, oh, that might be that one person, or oh, that happened over here, but it's not going to happen over here. They need the proof that this is an ongoing problem. Now this is the one that touched me. A deflated sense of self. Other studies had sort of alluded to sort of a lack of confidence in going to the doctor for deaf patients, but I feel like this is one thing that my study added to the research in. It was a clear expression of a deflated sense of self. And you read the quote, it says, now the first time I went to the doctor and had an interpreter, now understand for 2 years they refused to provide an interpreter. Finally I had an interpreter, I went to the office and I was so excited, I was happy. The doctor looked at the interpreter and said, what are you doing here? What are you here for? The interpreter said, I'm a sign language interpreter. The doctor looked at me and said, you can talk very well. Why do you need an interpreter? That deflated my spirit. And the look on her face when she was telling the story was it just really touched me. Because I hear this over and over and over in the focus groups, the deflated sense of self. And it did not always come at the hands of a physician. Sometimes it came at the hand of the interpreter. Because the interpreter took up a role that was not their role. And it really surprised me. I was not, as an interpreter myself, I was not expecting to hear that, but I heard it. That deflated sense of self at the hand of the interpreter. So what do we do about this? That means that we need more education for physicians. We need more education for the interpreters. But I also submit that we need more education for the deaf community. How to handle these situations. What types of questions should you ask? I think that there should be some health literacy programs for the deaf patients. Because like I said, that lack of incidental information, you cannot believe how much you miss just by that. Not having that incidental information. Or I think of, I'm married into a family that has a deaf child, and her mother would say, brush your teeth. Brush your teeth. Brush your teeth. So when she was about 17 or 18, I said something about taking one of my children to the doctor and they had a cavity. She said, what's a cavity? She had no clue. Her mom was hearing that she was deaf, and her mom really didn't sign very well, so all she would tell her child was brush your teeth. Whereas I tell my child, can't get all that candy because you're going to get a cavity, you better brush your teeth, or your teeth are going to fall out. I have a more extensive vocabulary to use with my child. But on the other hand, that hearing parent doesn't. So that lack of that incidental information, my child is 3 and knows what a cavity is. But my cousin was 18 and had no clue. That lack of that communication and incidental information is very important to healthcare, absolutely. So this particular study basically just supported all of the previous studies. The same things have been going on for over 20 years. It has not changed. There may be some pockets of places that are better than others, but this is still a problem 20 years later. And again, although it has been alluded to in the other studies, I feel like this particular study provided substantive data of that deflated sense of self. So, doing this. So the second part of this study, so after I finished, what I did, my goal when I went into this program, this master's program, was to do exactly this. So I started with a project in my first class and I carried it all the way through to the end. So after I did the first part of the research, and at SIUE they had no clue about the deaf community and they were all very excited, and they said, we cannot let it stop here. I just wanted my thesis. I just wanted to be done. And that was enough to be done. And I just wanted to relax. But then the deaf community kept coming up to me and said, you're not going to drop this, right? You're going to continue with this, right? And I said, absolutely. So it turned into a whole other thing. So after the focus groups, after we gathered all the data from the focus groups and looked at all the previous research, I applied for a grant and I received some funds to help create a training program for medical professionals. And in collaboration with Deaf Inc., I contacted Deaf Inc., and really Deaf Inc. has been there, was there from the beginning, from my first idea in the very beginning all the way up until the end, and they're still there, so they're absolutely wonderful. But I got the grant money and sat down with them and said, okay, what can we do? We wanted something basic. We just wanted to give basic information, something that we could have like at a nursing program at a college, or to provide some type of cultural exposure to the new medical students and nursing students that are coming through the program. So we decided to do this training program, which consists of a training video and a training manual. So, like I said, I contacted Deaf Inc. and to discuss part 1 and gain further insight into the direction, and they agreed to assist. And then in June of 2012, between the SIUE speech department, Deaf Inc., myself, and I applied for the Meridian Award and was granted, and that provided the funding. And then we began the production in February of 2013. And I will show a portion of the video at the end, but I will say we live and learn. So while we were doing this video, I decided it would be great to have medical professionals in the video, right? Real nurses, real doctors. Oh my goodness, they cannot act. Now I see the value of a good actor. If I ever get a chance to do this again, you need a real interpreter because they have to know how to sign. But everybody else will be actors. No more real people. I think the lights come on and they get scared and nervous, and I'm like, you do this every day. You take a blood pressure every day. But it was interesting. So. So the training manual itself had some key learning objectives. We wanted to provide awareness with regard to the deaf culture and, and the implications for communication. So just provide that basic awareness that deaf people are here, they have their separate culture, and they have their own linguistic language. We also wanted to provide knowledge of the laws that govern healthcare professionals with regard to working with people with hearing loss. Because for some reason, they seem to not know about the ADA. I don't know how they missed this, but they seem to have no clue. It happens every day, it happens all the time. I had a friend that I'm really close with, and she came over to my house one day and she said, you know, my daughter's getting braces. I need to sit and consult with this doctor, and he will not provide me an interpreter. So she came over, knocked on my door and said, would you please go with me? She begged me to go with her. So I printed off the ADA fact sheet and the Rehabilitation Act of 1973 fact sheet from the federal government page. I printed them and we got in the car and we drove up there. And I don't know, some of you don't know me, but I can be really in your face when I want to be. And that's exactly what I was. I went in that office with those papers and I showed it to them. And she was like, well, what is this? I don't know what this is. It's right off the federal government page. You can go there yourself and look. But if you do not provide an interpreter, this woman can sue you. And then what is that going to benefit you? You know, so after haggling with them, finally they decided to provide an interpreter. You know, they were kind of nervous and scared, and they were, I'm sorry, we didn't know, okay. But I don't know why they don't know. It's been around since 1990. How is this escaping them? I think they choose not to know. I think they choose not to follow it. They feel like this is going to be, hurt their pocketbook, so I'm just not going to do it. You know, and then they say, what choice do you have? Yeah, you can go try to file a complaint, but you need a doctor right now. You know, you file a complaint, it might be 3 months later before someone files a refuse. 6 months later, or maybe never. So, and they know that. So what are you going to do? So most times, what I've seen happen to deaf people just accept it and say, okay, I'll write back and forth, or I'll try to read the clips, or whatever. So that is proven to be a challenge, getting them to understand the law. So that was like the number one thing I wanted to put in the video. And it breaks down at the very beginning of your conversation. As soon as you call to make that appointment and say, okay, I need an interpreter, break it. So also part of the key learning objectives were to provide culturally and linguistically appropriate services for deaf patients, like give them knowledge of what that means. How does that look? What does that look like? And also to provide medical professionals with the skills and efficacy needed to be able to do that. You know, sometimes with health campaigns, like I'm a smoker. I don't know if there's any more smokers in the building. So you see all the ads about stop smoking, you know, it causes lung cancer and this and all kinds of strokes, high blood pressure, all these other things. And you would think I would stop. Because I know it, I've seen all the pictures of the black lungs and all that stuff, but I don't feel like I have the skill to do it. You know, so a lot of times people can have the knowledge, but then feel like they don't have the skill to do it. So not only do we want to impart them with the knowledge, we want to give them the skill to be able to actually interact with deaf people and feel comfortable. So how we decided to carry out these key objectives, of course, is by telling them about the laws, the ADA Act, the Rehab Act, the class standards. And all of these are not recommendations by the government. These are all requirements. They're not recommended. So we wanted to let them know. Also, we wanted to, how we plan to carry it out is give them the implications for a patient-provider relationship. You know, what does it mean, you know, what are the outcomes going to be if you decide to, you know, provide this interpreter or whatever, communicating with the deaf person in the way that they need. You know, what can be the outcomes? So we try to discuss things like in-group and out-group dynamics and cultural norms and expectations and just how to establish that trust with your deaf patient. And then those interpersonal communication skills, that's where it comes down to the skills and advocacy. So the training video it's supposed to be designed to where if you just wanted to do something short, you can watch the video and you can get some basic things. But it also has the manual with it, which adds to it, where you can actually get a trainer who comes and goes more in depth with the training. And in that training, if you have the actual trainer, we have a section where you will do mock situations, where you know, the students, whether they be nursing students or the hospital doctors, have mock situations where they have that person come in and sort of practice, you know, how to do this. Because, like, for me, as an interpreter, one of the things that really kills me is when I go into the doctor's office with the patient, and they come in, and the nurse starts talking, and she's walking the whole way. We're trying to go to the room, and she's like, "Hi, how are you?" And you're behind her doing this, and everybody's walking, and I'm like, that's just not really conducive to our conversation right now. But, you know, they don't know, you know, and that just might be an irritant to me. I don't know, maybe it doesn't irritate anybody else, but it's irritant to me. So anyway, so that second part is to provide them with some skills, you know, some mock situations that they can actually get up and do. And the training video, this is how the training video is structured. The first part starts with scheduling that appointment. And, you know, and in that first section, we talk about the laws and the federal standards. So when they call and make that appointment and they say, I'm not going to provide an interpreter, and this, that, and the other, we show the wrong way and the right way. And we give them the laws that pertain to it. The second situation is the initial intake. When you go into the office, sometimes the interpreter is not there. Sometimes it's through no fault of the interpreter. On the way here, literally on the way here to Andrade-Pereira, yesterday, I got a call while I was in the car asking me would I interpret in a hospital. Well, it just so happened the hospital was on the way here. So I said, okay. But they knew about that appointment. They knew about that appointment well before 45 minutes before the appointment. But they decided to wait till then to call to ask for an interpreter. So the deaf patient might feel like, oh, the interpreter didn't show up. It might not be the interpreter's fault. Maybe they waited late and didn't call that interpreter. So, you know, so I went on and I went to that appointment and then came on here, it was on the way, so I did it. But, so we go with the initial intake and coming into the office, the interpreter not being there, all the paperwork, all of that, and discussing some of the expectations and norms in that situation. And then we have the visit with the physician and what that looks like, and proper use of the interpreter and patient-centered communication. Okay, so now we're going to take some time and watch just the first segment of the video. This is the cover of the video. You might know some of these people.
Hello, Dr. Robert Harmon's office.
Hi, this is Video Relay Interpreter number 1234. I have a person using sign language calling your office. Have you ever used a Video Relay Interpreter before?
Yes.
Okay, hold one moment and I'll go ahead and connect your call. Hi, my name is Christine Womack. I'd like to make an appointment with Dr. Harmon.
I thought you said you were the operator.
Yes, ma'am. I'm the operator. I'm the interpreter. I can see the person using sign language on a video screen, and I will interpret for you everything they sign, and I will sign for them everything you say.
Oh, okay. I understand.
Hi, my name is Christine Womack. I'd like to make an appointment to see Dr. Harmon.
Is this for a regular physical or are you experiencing problems?
Well, I've been peeing a lot, and I've been really tired, and sometimes my eyes are blurry.
Okay. You said frequent urination, fatigue, and blurry vision.
Yes.
How long has this been going on?
About 3 months now.
Okay, hold a minute while I check the schedule. Okay, I'll be able to get you in on Friday at 10 o'clock.
Will you be able to get an interpreter by Friday?
Won't you bring someone with you?
The doctor's office needs to hire an interpreter, not me.
You don't have a family member or a friend you can bring with you to the appointment?
No, I do not have a friend or a family member that I can bring. Do you bring your friends or family member to the doctor? That's your responsibility to hire an interpreter.
Well, we can write back and forth, but we won't be able to provide an interpreter for you.
Writing back and forth would be fine if it were something simple like a shot, but I need to be able to communicate with the doctor about important issues. It's your responsibility to hire an interpreter for that.
Well, technically, ma'am, you're not a patient here yet, and we will not be able to cover the expense of an interpreter. Maybe you can contact another doctor's office that can provide that service.
Okay, so have you all had some of that happen? Can you bring your friend or family member with you? Do you bring your friends and family with you to the doctor? Or technically, you're not a patient here yet. So they're saying we're not going to provide an interpreter because you're not a patient here yet. Yeah, I'm calling to make my initial appointment. But those type of things are so common and they happen every day. So in between the section, we see that section and then we have the next section.
Hello, Dr. Robert Harmon's office.
Hi, this is Video Relay Interpreter number 1234. I have a call for your office from a person using sign language. Have you ever experienced a video relay call before?
Actually, no, I have not.
Okay. I'm a sign language interpreter, and I can see the person using sign language on a TV screen. I'll be interpreting for you everything they sign, and everything you say, I will sign for them. You can go ahead and speak as you normally would. Hi, my name is Christine Womack. I'd like to make an appointment to see Dr. Harmon.
Is this for a regular physical or are you experiencing problems?
Well, I've been peeing a lot, and I've been really tired, and sometimes my eyes are blurry.
Okay. You said frequent urination, fatigue, and blurry vision.
Yes.
How long has this been going on?
About 3 months now.
Do you need an interpreter present at your appointment, or is lip reading or writing sufficient?
I will need an interpreter.
Okay, we do have an appointment available tomorrow at 1:30. We also have Monday at 8:30.
I would prefer tomorrow, but if you cannot get an interpreter for tomorrow, I'll take Monday.
Okay, I will call to see if we can get an interpreter tomorrow. If not, I will request one for Monday. Since you've never been here, on the day of the appointment, I need you to arrive 15 minutes early to fill out paperwork. Please bring your ID and your medical insurance information. How do I contact you when we have confirmed an interpreter?
You can call my video relay number. That number is 618-555.
Okay, someone will contact you soon.
Thank you.
Thank you. Goodbye.
Okay, so that's the beginning part. And like, how many people have a video relay call come through and the person goes, utilize the services, you know. So that was one of the things that we wanted to show also, that exchange, because when you say video phone, people are just like, what's that? Which is interesting because now everybody has a webcam and we all, you know, use that, but the concept of video interpreting seems to be foreign sometimes to people. So that's the first part of the video and sort of how it goes. And the rest of the videos follows that sequence. You see the beginning, sort of, you know, the situation that is less than best, and then we see the improved situation, you know, with some narration in the beginning, in the middle, and then the improved situation. So the video sort of goes like that. So the hope, and the hope with this is, now that we've finished the video, is to test it. Because again, the doctors want proof. You know, does this work? You know, you said this, but does it work? So the goal is to test this out on nursing students at SIUE next semester. And, you know, do a pre-test and a post-test sort of situation. And see if it's successful. You know, to see if they feel like they really did gain some competent skills and knowledge from the video. And if we can prove that something like this is successful, then it takes you one step closer to getting something like this accepted by the American Medical Association. Because doctors need continuing education units just like we do. So if we can get something accepted by the AMA, then that gives them a buy-in. They can get their credits, you know, for taking some type of cultural class. And what's interesting, I looked on the AMA site, they have cultural competency training in Chinese, Hmong, and Vietnamese, every other culture. But I did not see one that talked about the deaf and hard of hearing community, and I just thought that's egregious, that's ridiculous. So hopefully we can do something like that to, you know, at least provide the awareness and education so we can stop saying, that stupid doctor, he didn't even know this, or they didn't know this, because I say it all the time. So the next question is, so where do we go from here? What is the next step? You know, I talk about research, and people say, why is research important? Like, I did this study, right now I'm working on a study in the deaf community about medication error. You know, sometimes people take medication wrong, or they don't know what medication is for, and I'm trying to do one on medication error. And a lot of times deaf people say, well, I already told you my story. Sometimes we're looking for something specific. This was more general communication question. But right now we're doing research on specifically medical error. So people say, well, I did this, why do I have to do this? Because we need your story. Without your story, we can't prove to medical professionals that this is an issue. They don't know that maybe taking that label on the bottle doesn't that you don't understand that. They don't know that. So if we can give them proof that this is a problem, then maybe we can improve services. So for the deaf community, I say do not hesitate to get involved with some of the research. I know when I did the first focus group of medication error, some people dropped out because they saw the video camera. Well, your language is visual. The only way I can capture your language is on video. Now, what we tend to do is take that video, translate it into English, and write it out, and then the video is destroyed. But a lot of people were like, I don't want to be on video. Well, that's the only way I can capture the language. So I would, encourage the deaf community to, just get involved. I think there should be more research done on health literacy in the deaf community because that area is so sparse. And just medical information, what's the best avenue to get that medical information to the deaf community? Now, as far as training, I think that we all could use training. The medical professionals, the interpreting profession, because some of the things that I heard in here about us interpreters, I was kind of shocked. So maybe we need to do something about, medical vocabulary, about your role as an interpreter in the healthcare setting. And then for the deaf community, it's more education about healthcare matters. So this sort of concludes my presentation here. I wanted to ask you all if you had any questions, comments, concerns, suggestions. Where do you think we should go from here? What should be the next step? Oh, right. Also, if you do have a question or a comment or a suggestion, would you please come up here to the front?
share a personal experience. It was actually when my husband was going through cancer, or experiencing cancer. He had a morphine portal. And there was a machine that would monitor the morphine drip every 20 minutes, that would do that automatically. He was having much pain, one particular instance, so we tried to notify the nurse. She came to figure out what was going on, and there was an interpreter with her, and the interpreter was a wonderful interpreter. However, the oncologist and the nurse, they were not communicating. So it was very interesting that what the actual problem was, the morphine diagnosis, or the morphine amount should have been 0.5 milligrams, which is a very different amount than 50 milligrams. So it should have been 5, but it was actually 0.5, which is why he was experiencing so much pain. And I didn't know this difference. I didn't realize the difference between 0.5 and 5. So the miscommunication between the doctor and the nurse didn't get relayed to me because I didn't see that issue. Well, then they gave him 5 milligrams, and he then all of a sudden had hallucinations and was having a horrible reaction after 20 minutes. I called the nurse immediately to come and see what was going on. She identified that it was actually an overdose, that the doctor had said 0.5 milligrams. So, just as a warning for all of you, please make sure to know if the correct dosage is being used. It can be very dangerous. I learned a lot from that particular experience. I mean, 0.5 and 5 is a big difference, right, Valerie? Yeah, 0.5 is much less of a dose. So it was amazing to see the change that my husband experienced. I mean, it was in a matter of minutes that I saw the morphine take effect. It was scary. It was a scary experience. And if you're a caretaker, not even the patient themselves, there can be miscommunications between the medical professionals. And I didn't fully have the understanding of the medical situation, so sometimes there's human error, right? But we all need to be very careful in medical situations. We need to be very careful. So I just wanted to share that experience.
My name is James Marks. I'm a lawyer. I work for Deaf Inc. and we're excited to work with Valerie. And these videos are fantastic, and the program you're putting together is outstanding. I'm so excited that you're moving forward with that. I wanted to share some experiences that I've had working with deaf people, especially in medical setting, regarding obtaining interpreters. A couple ideas I've got for you that you might want to consider when you're making those calls to try to get your doctor. First thing is that if you call into the video relay service and you tell that operator that you don't want that doctor's office to know that you're using an interpreter, you can tell her that, and they won't start the call off appointment immediately, say, thank you very much, write down the name of the person, the time that you called, and end the conversation. And then you call back, maybe a day or two later, and you say, by the way, I want to let you know I'm deaf and I need an interpreter. See, that keeps them from being able to say, oh, geez, we're all filled up. We don't have any more appointments. Okay? Now they're kind of stuck. And you got the name of the person who told you and made the appointment for you, so they can't get out of it. And by telling the operator, not to identify you as a person who uses sign language, they're not going to know you're deaf at that point either. Now, the reality is most of these people, at least that I've dealt with, really aren't interested in not giving you an interpreter. They just don't know any better, and all of a sudden they're worried because they don't know, they don't want to be wrong, and they don't want to screw this up. Plus, they're usually not the doctor, and they're usually not the person in charge, and they're going to have to tell their boss that there's some money that he's got to pay. And doctors hate paying money for interpreters. So the point is that oftentimes the people on the phone is not your enemy. They're stuck in the middle. So be mindful of that. Be very pleasant and patient with them because they really will help you out. So I don't want to take up Valerie's time, and I don't want to take anything away from what she said. I agree with everything she said. But I wanted you to know that first call, and this applies to doctors, this applies to lawyers, this applies to police, all these kinds of things. You can use this process in the same way. So,
Before you leave, I have a question for you because before we came in, were you about to ask?
I gotta ask a question for the lawyer. So I call back the second time and I say I need an interpreter, and then they refuse me, or they say they're not gonna help me. Then what do I do?
well, take their name again, write the time down, and say thank you very much. Find out what their position is in that organization. Make sure this person's the decision maker. Because, if the secretary screws up, it may not be the final word. You know what I mean? Say, okay, is there someone else I can talk to? Do you have an office manager? And they might try to push back a little bit, but if you persist and say, I need to know the name of your office manager, please, and if they won't give you that, then you can call back later and ask to speak to the office manager. But you want to work your way up the chain and say, hi, I talked to Barb about 20 minutes ago, and she told me that even though I'm deaf and you're required under the ADA to provide me with communication access, she's refusing to do that. Is that true? Is that what the policy of your organization is? You see, when you bring that information to me as a lawyer, and I say I'm trying to help you find someone to maybe pursue that case, I've got evidence now. Because if we don't write this stuff down, what happens later is that they say, I didn't hear anything, nobody called me. He called and said, never mind, I don't want anything. They make stuff up. So you follow it up the chain, and you keep getting evidence. Down the road, if they refuse to cooperate, you can call me at Deaf Inc. I will make that call. And what's nice about that is that I will try to resolve it right there. Usually when there's a lawyer on the other end, they're a little more receptive because they realize you mean business, right? And if that doesn't work, we'll refer you to lawyers and you can sue them. But the point is, you guys want a doctor, you don't want a lawsuit, right? So, does that answer your question?
Well, it does.
I mean, I'll go into it in more depth.
No, that's great. Thanks.
You're welcome.
That's the thing. I was talking to him this morning at breakfast, and I told him to call you. That's why I told him this morning to call you. So great, thank you.
Thank you, Valerie.
Say, more questions.
I'm just glad to have an attorney here. I'm a social worker professionally, I'm a social worker professionally, and I come across the problem with doctors' offices or podiatrists saying, no, we can't. You still get them? Yes. Okay, so they still say, well, we can't afford it, and I've heard from other people that said that if they can prove financial hardship, if they can prove that they can afford it, and that's usually if they have less than 15 workers, then by law, they don't have to provide an interpreter.
And you're right.
Well, there's multiple aspects to that. I would kind of caution people not to get into the law too much with the doctors when you call. Because when you get in an argument with people about what the law is, then their egos come up, and they'll start arguing with you, and it has nothing to do with interpreters anymore. I'd be happy to answer your question about the law. I think I know it, but I just wanted to point that out. The best thing to do at that point, when you start getting that resistance, is to say, look, do you understand this give this person the right care, it's going to kind of come back on you. The ADA also requires you to do this, and that's why. But you know, really, this person is going to be able to communicate with you. What are you going to do? But in answer to your question about the law, the 15 employer thing doesn't apply to public accommodations. Okay, so if I'm for example, a lawyer in private practice, right? If I have my own office and you walked into my office, same thing with a doctor. You walked into my office and you said, you know, I want a consultation with you. At that point, I'm stuck. I have to provide you with an interpreter because I can be able to communicate with any hearing person that same way. And a doctor's the same way. It doesn't matter whether I got any employees for public accommodations. The other question you asked about, that does, the 15 employers, I think, applies with regard to employment law. They're Title I of the ADA. But for public accommodations like we're talking about here, there's no number requirement. Your question about the money, right? How much money, how much income they have to have. Doctors oftentimes are mistaken about this. They look at it like your little situation, like, well, she's only going to pay me $120, but then that interpreter is going to cost me $130. So this isn't good for me. This isn't fair. I don't have to do it. No, that's not right. They look at their whole enterprise and they say, would providing an interpreter for this person ruin my business? And if it's not going to ruin my business, then I got to go on. That's the law. Now these guys don't realize that, and yelling at them and telling them that really isn't going to change their mind. That's why they'll figure that out when their lawyer tells them. You know, they'll call their lawyer. Their lawyer will say, no, that's not true. That can't be right. But then 2 days later, the lawyer will call back and say, man, I got bad news for you. It's true. And you know, you better call that person back and hope they don't sue you, because it's going to cost you a lot more to pay me to make the lawsuit than it is to hire that attorney.
And I think we have to start letting them know that it is more cost effective
Right.
to hire that interpreter now than to pay for it later in the end, right?
Right, and the other thing that's really important is when you're in that middle of that conversation with that office staff, you want to be able to see, how can I make them believe that I'm trying to save them money? Because that guy's thinking, are you kidding me? Every time I talk to this person, I got to pay $60, $70, $80 an hour? Maybe you say, look, I want to be reasonable. I'd love to work with you, but I can't do notes all the time. This stuff's complicated, and I don't understand these medical terms, and I don't speak English as my primary language. So, you know, we can work something out. Maybe we don't have to have an interpreter all the time. In fact, one more thing I'll say.
And we want to get to.
I'm sorry. One more thing I want to say. It's a good idea to ask that doctor's office to set up a meeting to discuss communication access, because that doctor has a requirement under the law to provide, to make that determination. And just because a deaf person says I need an interpreter, that's not the way the law works. The doctor has to figure out what that deaf person needs. So there needs to be a meeting of the minds about that. The doctor has a duty to do an investigation. And so you can offer, say, let's just have an interpreter there so we can talk about whether you need an interpreter. And then you might be able to save the doctor some money, and then they'll love you.
Hi, my name is Tony Bullard. I work full-time at Barnes Jewish Hospital. I find that with our system, often if you get resistance and with other doctors' offices, with the folks that I work with, they go off our campus, is if you get at least a little resistance from the very beginning, ask for the doctor. I'm going to tell you right now, 99% of the time, the doctor really has no clue what's going on in that office.
I couldn't agree with you more. You're right.
And usually they're kind of, frustrated and flabbergasted, and will set whoever straight in line of, what's going down.
Especially some of the new doctors. You know, this came out in 1990. There's a lot of old doctors out there.
But they, like Valerie was saying, John, the ADA, we have to start playing nicer with interpreters and deaf people and work together to educate these folks, whether it's a medical center or just a doctor's office, to educate them on the ADA, the remit, but they don't know. Why would they know? I mean, it's like when you walk in and they're trying to give you a new medicine, what if they're going, why don't you know?
Right.
Haven't you heard of medicine? I mean, really, it's the same respect issue. It's constant, non-stop, having to educate people. And Valerie, you're talking about, you get done with the ITP, you're just starting your study. You don't get access to specific medical NITP. It's a generic, general program. So your work is just starting with research and study, and that's an avenue that you can go down.
So, I've had two different experiences. James Mark suggested, I've taken that approach before. It wasn't that I called and then called later. What I did was I said, you're required to use or to provide an interpreter. That was the approach I used to take. But what I've noticed is that not necessarily the doctor, but the office manager, their response changed. When I take more of that direct approach and hard approach, if you will, in requiring an interpreter and insisting that they must meet the ADA, that what I get back is some haggling and maybe their insistence on, well, I'm just required to provide effective communication. It doesn't explicitly say interpreter. And instead, if I take more of an approach like what has been recommended, if I take more of an approach that's more positive and inquisitive about if they've had an interpreter before, that they respond to me differently. It has a huge impact in how you receive the services. If you start off in that hard tone, that will be met with, they will meet you with that. And you know, I have to say, I used to go into a doctor's office and I could feel this tension. I could feel the vibe by the office staff, even by the doctor, which was very uncomfortable. And when I changed my approach and had a softer approach and take more of an educated, sort of educate them, then they met me differently. That tension and that vibe was not there. So it really will have an impact. The first impression we make is an important one. So just some food for thought.
Thank you. Well, that's absolutely true. We have to educate them. We have to talk to them. Well, the majority of the time, it's just they just don't know. They're just not aware. They've had no contact with this community, so they don't know. And even at SIU, when they became aware of my study, the pharmacy is the one who said, we didn't think, how might this affect pharmacology students? We went to pharmacy, and that's what led to the medication error study that we're doing now, because they had never been exposed to it before. So I hope that you all have enjoyed the presentation, maybe learned something that you didn't know, or a lot of it is, like I said, not rocket science. We know it. We need to get them to know it. So that's the goal. And if you have any comments or suggestions for me later, please feel free to come up and let me know. Thank you all for your time.